Good morning, everyone. Welcome to the Orlando GI Journal Club. This is March 5th, 2025, and 7 a.m. Eastern Standard Time. Our first study is a study published in Clinical Gastroenterology and Hepatology. This is a real-world effectiveness of FMT for first or second C. diff infection. C. diff infection can result in mild diarrhea to fulminant colitis, and it's associated with significant mortality rate, especially in elderly patients. Current guidelines recommend treatment with fidaxomicin or vancomycin as standard of care at the first or second C. diff infection episode. Fecal microbiota transplantation, or FMT, is highly effective in recurrent C. diff infection, but remains reserved for third C. diff infection episode or antibiotic refractory or fulminant C. diff infection. In a randomized trial, FMT was superior to placebo for first or second C. diff infection treatment. And these authors wanted to evaluate the effectiveness of FMT in a real-world prospective cohort in patients with first or second C. diff infection episode. This was a multicenter cohort study in Denmark. Patients with first or second C. diff infection were treated with FMT from June 2019 to 2023. February, they enrolled 467 patients. FMT were administered through capsules, NJ tube, or via colonoscopy. The FMT treatment was always preceded by vancomycin, vancomycin, fidaxomicin, metronidazole, or combination of these antibiotics. C. diff infection recurrence after the first FMT treatment, treated with C. diff infection-specific antibiotic, followed by new FMT treatment from another donor. Severe C. diff infection for this study used the Danish guidelines for C. diff severity and was defined as hypoalbuminemia, leukocytosis, leukopenia, abdominal pain, or acute kidney injury. Fulminant C. diff infection was defined by presence of fever, cognitive impairment, hypotension, ileus, toxic megacolon, pseudomembranous colitis, or multi-organ failure. The primary outcome measure was the cure of C. diff-associated diarrhea at 8 weeks after the last FMT. A total of 467 patients were enrolled in this study. Mild to moderate C. diff infection occurred in 116 patients. Severe infection occurred in 262 patients, and fulminant C. diff infection occurred in 89 patients. The majority of patients in this study had a second infection of C. diff infection, 60%, and 40% had first C. diff infection. Antibiotics were given pre-treatment, so pre-FMT in 96% of patients. In all patients, with 96% of patients being administered vancomycin, fidaxomicin 8%, metronidazole 6%. No pre-treatment was given in 3 patients. For refractory disease, patients were described as having antibiotic refractory C. diff infection in 36% of cases, and the majority of the patients underwent FMT administration via capsules in 89%, NJ tube in 8%, and colonoscopy in 3%. The cure of C. diff associated diarrhea following first FMT, the treatment success was 76%, was defined as cure of C. diff associated diarrhea at week 1 in 76% of patients. At week 8 post FMT, cure of C. diff associated diarrhea was seen in 55% of cases. 90-day mortality overall was 10%. Now, if you look at patients with either severe or fulminant C. diff infection, in patients who had non-refractory C. diff infection, at week 1, cure rate was 78%. At week 8, the cure rate was 54%. For antibiotic refractory C. diff infection, cure rate was 74% at week 1, 46% in week 8. As you can imagine, for fulminant C. diff infection, the treatment success rates were lower, especially if you look at antibiotic refractory C. diff infection. Success rate was 60%, and at week 1 and 36% at week 8. The limitation of this study was that they were unable to compare FMT administration according to the various forms of administration or dosing regimes. The Danish guidelines were used for grading C. diff infection severity, which led to an overestimation of severe and fulminant C. diff infection, and they had no control group to directly compare cure rates in patients treated with FMT versus antibiotics. The take-home point from this study is that in a real-world setting, repeat FMT treatments were highly effective in patients with first or second C. diff infection. Our second study was published in Gut. This is Drews et al. This is a multicenter randomized trial looking at the Purestat self-assembling hemostatic gel to prevent delayed bleeding following EMR. EMR, or endoscopic mucosal resection, using electrocautery enhanced stent, also known as hot stent EMR, is the standard approach for removing large flat lesions in the duodenum and colorectal region. Clinically significant delayed bleeding occurs in 4 to 11% after colorectal EMR and in 8 to 18% after duodenal EMR. Topical hemostatic agents are compared to clips, easy to apply, you don't need much training, and they can be applied very quickly. The aim of this study was to evaluate whether prophylactic application of Purestat, which is a self-assembling peptide hemostatic hydrogel, to the resection field reduces delayed bleeding in colorectal and duodenal lesions. This is a multi-center randomized trial conducted in Germany involving 15 centers. The authors included patients undergoing both colonic EMR and duodenal EMR. The inclusion criteria for size was at least 10 millimeters for lesions in the duodenum and at least 20 millimeters for lesions in the colon. The study allowed prophylactic clip closure, did not allow prophylactic clip closure, but they were allowed selective clipping or coagulation prior to randomization to treat intraprocedural bleeding or for prophylactic treatment of visible vessels. After EMR and then selective clipping or coagulation for intraprocedural bleeding or after prophylactic treatment of visible vessels, patients were then randomized in a 1-to-1 ratio to hemostatic gel versus no gel. The primary outcome was delayed bleeding within 30 days. This randomized trial was stopped early due to futility at interim analysis. So the total number of patients enrolled in the study was 232 patients, 208 colonic and significantly lower number of duodenal polyps, 26 cases of duodenal EMR. In terms of the patient demographics, if you look at the majority of patients, were men with 46% female in the Pyristat group, 44% females in the control group. The mean age was 67 years in the Pyristat, 68 years in the control group. In terms of SA class, majority of patients were SA class 2 or 3 at 68% versus 69% in the control group. If you look at the use of anticoagulation and antiplatelet agents were used in 23% in the hemostatic gel group, 17% in the control group. Anticoagulants were used in 13% of hemostatic gel group versus 22% in the control group. These are the polyp characteristics. So if you look at just the colorectal lesions, 47% of lesions were in the cecum, 71% in the ascending colon. When looking at the Paris classification, the majority of the polyps were flat, 2A on its own, or 2 combined with 1S. And if you look at the sizes, 30 millimeters median was the median size, and the size of resection area varied. From 7 centimeters, interquartile range was 4 to 11. For histology, the adenocarcinoma was seen in 8% of cases in the colorectal EMR group. High-grade dysplasia in 47%, and then low-grade adenoma in 90% of the cases. For duodenal lesions, there were 26 duodenal EMRs performed overall. In terms of the histology, high-grade dysplasia seen in 2% of cases, and the remainder were tubular adenomas. These are the measures that were taken prior to randomization to either the gel versus nothing. And as you can see, for treatment of intraprocedural bleeding, clipping was performed in 18% of the gel group versus 20% of the control group. Epinephrine injection took place in 2% of gel group and 2% of control group. Stenotip coagulation occurred in 26% of gel group, 25% of the control group, and Coagrasp was used in 13% of the gel group versus 7% of the control group. These patients underwent clipping for deep mural injury or perforation during EMR. And this occurred in 1% in the gel group versus 2% in the control group. So the performance of BRILIANT prophylaxis prior to randomization was again was similar between the two groups. 62% in total overall in the gel group versus 59% in the control group. So this is the outcome measure. If you look at the incidence of clinically significant delayed bleeding, it occurred in 40% of the gel versus 7% of the control group. And as you can see, there was no statistical significant difference between the two groups with p-value 0.227. If you're looking at just colorectal EMR, bleeding occurred in 10% of the gel versus 5% of the control group. For duodenal EMR, bleeding occurred in 4% in the gel versus 2% in the control group, and none of the p-values are statistically significant. The authors also performed a subgroup analysis looking at incidence of delayed bleeding in patients who had no clips placed. As you know, this is the only measure that's been shown in randomized trials to prevent delayed bleeding after colorectal EMR. So if you look at the subgroup of patients who had no clips placed at all, again, there was no significant difference between the gel versus control group at 7% versus 2%, p-value of 0.174. If you look at colorectal lesions and duodenal lesions, again, no difference between gel and nothing with incidence of bleeding at 3% for gel versus 1% in the control group, and the for colorectal lesions and for duodenal lesions, 4% bleeding with gel versus 1% bleeding in the control group. The limitation of this study is that the subgroup analyses were performed for duodenal and colorectal lesions, but not for other variables such as polyp size, colonic location, or anticoagulation use. Again, this study was stopped early for futility at interim analysis. And so if you look at the number of duodenal lesions, it's only 26, which is a relatively small number. Next limitation is that there's a high rate of preventive measures after EMR, consisting of selective clipping or coagulation methods. And it is not clear if there would have been a difference in bleeding rates in the absence of preventive clipping or coagulation use. And for the study, only hot snare EMR technique was used. And so we don't really know how to extrapolate these results for patients who underwent cold snare EMR, and there were no ESD patients in this study at all. So the take-home point from this randomized trial is that the application of the hemostatic gel, Puristat, following EMR of large flat lesions in the duodenum and colorectum does not reduce the rate of delayed bleeding after EMR. Our next study is a study that we have published looking at the rate of suitable cases for primary EUS-guided biliary drainage and distal malignant biliary obstruction, published in GUT. ERCP is the preferred therapeutic strategy for malignant distal biliary obstruction. However, duodenal invasion by tumor can limit technical success. And stent dysfunction from tumor ingrowth and post-ERCP pancreatitis are also limitations to ERCP. EUS-guided biliary drainage has emerged as promising treatment alternative for ERCP. However, for EUS-guided biliary drainage, technical maneuvers such as accessing the bile duct using a 19-gauge needle to enable guide wire passage, and if you're using luminary metal stent, it also requires a sufficiently dilated common bile duct for it to be technically successful. Currently, it is unclear what proportion of patients with malignant distal biliary obstruction in routine clinical practice present with bile duct diameter of less than 12 millimeters, so non-dilated, not significant dilated bile duct that would preclude a primary US-based intervention. So this was a retrospective study conducted here at the Digestive Health Institute in Orlando Health of patients who underwent ERCP or EUS-guided biliary drainage from 2022 to 2024. ERCP was the primary treatment modality, and then EUS-guided biliary drainage was reserved as a rescue technique for failed ERCP, and we included all adult patients with malignant distal obstruction undergoing index biliary intervention by ERCP or EUS. And the primary outcome of our study was the proportion of patients undergoing EUS-guided biliary drainage or ERCP who had a dilated bile duct. Over the study period, a total of 406 patients underwent ERCP, 29 patients underwent EUS-guided biliary drainage. The mean age in the ERCP group, 69.6 years. In the US group, 70.9 years. The total bilirubin was 8.8, mean of 8.8 milligram per deciliter in the ERCP group, 10.7 in the US group. The bile duct diameter in the US group was significantly larger at 16 millimeters compared to 12.3 millimeters in the ERCP group. Procedure duration was significantly shorter at median of 13 minutes in the US group versus 18 minutes in the RCP group. Now, this is the flow diagram of patients who were enrolled in the study. So over our study period from 2021 to 2024, a total of 3,201 patients required an ERCP, and in patients with endoscopically accessible papilla were 2,416 patients, of which 439 patients had a malignant distal biliary obstruction. ERCP was successful in 92.5% of these patients who had a common bile duct diameter ranging with interquartile range ranging from 10 to 15 millimeters. In the patients with malignant distal biliary obstruction who failed ERCP, that was 33 patients, or 7.5%. 29 of these patients were able to undergo US-guided intervention successfully with CBD diameter interquartile range of 13 to 18 millimeters. And those who failed US-guided biliary drainage, the 4 patients underwent percutaneous transhepatic biliary drainage. In the 29 patients who successfully underwent US-guided biliary intervention, you can see on this graph here that there is a negative correlation between bile duct diameter and procedure duration, i.e. larger the bile duct diameter, shorter the procedure, i.e. it was an easier procedure to do when the bile duct was dilated. So in total, if we look at our patient population, 197 of 439 patients, that's 45% of patients who had malignant distal biliary obstruction at clinical presentation had common bile duct that was less than 12 millimeters in size, and that would preclude an US-guided intervention. The main limitation of this study is that this is a retrospective study, and therefore with inherent limitations associated with retrospective database study. And the take-home point from our study is that 45% of patients with malignant distal biliary obstruction who underwent ERCP had common bile duct diameter less than 12 millimeters. That would have excluded them from undergoing an US-guided biliary drainage. And therefore, given current technical and technological limitations, US-guided biliary drainage would not be an ideal proposal as an alternative or first-line treatment for patients with malignant biliary obstruction, because it would really be only effective in only 60% of patients, as only these 60% of patients would qualify for this intervention. So for recap, repeat fecal microbiota transplant treatments were highly effective in patients with first or second C. diff infection. Application of hemostatic gel following EMR of large flat lesions in the duodenum and colorectum does not reduce the rate of clinically significant delayed bleeding. And in our study, 44.9% of patients with malignant distal biliary obstruction who underwent ERCP had common bile duct diameter of less than 12 millimeters. That would exclude them from undergoing US-guided biliary drainage, and therefore it would not be realistic to propose US-guided biliary drainage as an alternative to ERCP because it is a technique effective in only 60% of patients with malignant distal biliary obstruction. So thank you so much for joining us this month. Our next monthly GI Journal Club is the first Wednesday of April, which is April 2nd, 2025. Thank you so much for joining us. Please have a wonderful day, week and month. And thank you so much. Take care. Bye.